Bismillah Rahman Rahim. Let us talk about stomas. Here we have a scenario. It is saying that what type of stoma is most likely to be encountered in a 56 years old man underlying a low anterior resection for carcinoma of the rectum with a colorectal anastomosis. So we have loop colostomy, colostomy, endoleostomy, loop ileostomy, and cecostomy. The answer is loop ileostomy. Let's study all of them one by one. So first of all, uh, we are studying about the gastrostomy, that is percutaneous endoscopic gastrostomy or PEG. It is a procedure that is done endoscopically. Okay, an endoscope, that a camera is passed through an esophagus into the stomach to see the anterior part, and the a tube is passed percutaneously to the stomach, and then that is fixed. It is mainly used to decompress the stomach, and it is also used for feeding purposes. Most commonly the location is in epigastric region. Another one is loop jejunostomy. It is very rarely used, but in some cases we can use it, and the tube is placed uh, inside the lumen for feeding purposes. Okay, most commonly the location can be decided according to the patient need and which part of the abdomen it can. Most commonly it is an left hypochondrium. Percutaneous jejunostomy usually performed for feeding purposes. It is mainly, we can do it laparoscopically as well. So the site of percutaneous jejunostomy is the proximal bowel, like from DJ about 2 feet proximally we will find the proximal part of the jejunum, and we are placing a tube. Most common places in left upper quadrant. Another one is, this is also the picture of percutaneous jejunostomy. Okay, and another one is loop ileostomy. It is used in defunctioning of colon following a rectal cancer. It is not decompressing the colon if ileocecal valve is competent. Okay, if it is incompetent, the contents from the colon also come through the ileostomy, and it will be drained into the stoma bag. Usually it is commonly done in the places in right iliac fossa. Here we see it has a proximal loop and a distal loop. Proximal loop is the loop where the fecal matter is drained, and the distal loop is actually here a mucus fistula. Mucus fistula means the mucus and the contents of the gut that is produced, it is drained through this mucus, and the location of these two loops is the proximal loop mainly. This is the a diagram, but we practically make a proximal loop inferior laterally and mucus fistula superior-medially. Okay, because the fecal matter that is drained, it should be inferior-medially to directly drain into the bag. And another one is end ileostomy. End ileostomy is usually done following a complete excision of colon where ileocolic anastomosis is not planned. Okay, may be used to defunction colon, but a reversal is more difficult. Here you can see in this diagram, colon is removed and an end ileostomy is made, mainly in the places in right iliac fossa. Another one is end colostomy, where the colon is diverted or resected. Resection anastomosis is not primarily achievable. Okay, for example, when you remove the sigmoid and also the rectum, then you made an endostoma, that is colostomy. Mainly it is in left iliac fossa. Another one is loop colostomy. In this picture we see the two loops of colon that is brought outside. It is called loop colostomy. It is mainly to defunction a distal segment of colon, and may be located in any region of abdomen depending upon the colonic segment that is used. Okay, if we use a transverse colon, it may be in epigastric region. If we use the ascending colon, it may be in the right quadrant, and if we are using a descending colon, it may be placed in the left quadrant of the abdomen. Another one is cecostomy. Cecostomy is a stoma of last resort. Like if we are having no option, no other possibility, we make a uh, cecostomy. Okay, here in this diagram a tube is placed in the cecum, that is cecostomy tube. Okay, and another one, this is less, very rarely used, appendicecostomy. During the formation of appendicecostomy, the appendix is used for the stoma. Here we see this is the appendix and the cecum. The appendix is used, and the catheter is passed through the abdominal wall into the bowel and to the appendix, and the cuff is inflated so that the catheter is not removed. This is called appendicecostomy. And another is mucous fistula. As we said earlier, mucous fistula is the distal loop. Whenever we want to uh, drain the mucus, or like we make this mucous fistula and the end colostomy. This here, from the end colostomy, the gut contains the fecal matter is drained out, and from mucous fistula the mucus that is produced by the gut is drained back out. So we have the types of operation. If we are doing partial colectomy, so we have two options: to primary anastomosis and make a loop ileostomy here in this operation, or we can make a uh, loop double barrel uh, colostomy. Okay, double barrel is like if we are bringing two these a part of gut is resected and the two lumens are brought out, that is double barrel. If we are only cutting the anti-mesenteric border of for example ileum, and bringing it bound out, and the posterior wall is intact, that is loop ileostomy. And here in partial colectomy, we have two options. As I said earlier, we can make a primary anastomosis of the colon and defunctioning loop ileostomy, and we can make a double barrel colostomy. If you are doing a right hemicolectomy, we also have two options. We can make a ileostomy with mucous fistula. The ileum will be a ileostomy, and the distal part of transverse colon is that maybe a mucous fistula, or we can make a primary anastomosis of these two. Left hemicolectomy, where the splenic flexure and descending colon is removed. We also can have an anastomosis, or we can make a colostomy. Sigmoid colectomy, same as previous, we can make a anastomosis and we can make a defunctioning loop ileostomy. Lower anterior resection, same. And total colectomy, we are removing all the part of the colon, but the rectum is not removed. Proctectomy is that we remove the rectum, only the rectum. Okay, and a total proctocolectomy is the removing of all the large gut plus the rectum. The abdominoperineal resection, it is a removing of sigmoid, the rectum, and making and and colostomy, that is permanent stoma. Okay, so in colectomy we have left hemicolectomy, right hemicolectomy, and a sigmoid colectomy and subtotal colectomy. In subtotal colectomy we see the sigmoid is not removed. Okay, we may face different scenarios that in which condition we are making which stoma. Okay, so one MCQ was containing an answer if we have a distal esophageal tumor and that is resected, anastomosis, that is I will with esophagectomy, which stoma is made. In this condition no stoma is made. Okay, no stoma. And now we are studying again that MCQs, what type of stoma is likely to be encountered in a 56 years old man undergoing a low anterior resection for carcinoma with a colorectal anastomosis, that is loop ileostomy. If we are anastomosing the colon, we should make a defunctioning loop ileostomy to ensure that our stoma is not leaked. Okay, then we will wait for 3 months, 4 months. After that our anastomosis matured, and we will then reverse the ileostomy. The reversal of ileostomy is much easier than the colostomy. Okay, thanks for watching.